The emergency department is really tough when it comes to the way we handle miscarriages. And being on the other side now, I'm able to see two sides of the table. Prior to suffering a loss myself, I would have to say that I treated a miscarriage, like I would treat other different ailments that come in through the emergency department. So there's the element of triage. Is this person dying? Is this person not dying, right? And if this person is dying, I'm bringing them in. We're doing all the things. If they're hemorrhaging, like bleeding, we're doing all the things. If they're not dying, or if their triage level is low, they're going to sit in the waiting room, right? I'm not thinking about the emotional toll. I'm not thinking about the shame, the humiliation that comes with sitting in a waiting room. I'm not thinking in that way. I'm thinking about moving the meat. It's a lot of things that are going through the emergency physician's brain. It's about moving the meat. It's about taking care of the sickest patients. And so your perception of what somebody is going through, you may not feel or empathize with that. And so it becomes a really difficult place for people who are experiencing such a loss. We then discuss what they can do at this point. For some people, it's watching and waiting, which is what we call expectant management. And then for other people, it may look like, I need a little bit of help getting everything out. Maybe it's just a little spotting and I just don't want to go through this. And that may look in the form of medications. And for really rare cases where, maybe expectant management doesn't work, or they may not want to take medications to help and they want to be done with this, we do offer something called DNC, but it's not typical how we start unless there's some complication, like there's a lot of bleeding or there's infection. It's not always the first choice.